acute chest and multi-organ failure that are really killing our adult patients most of the time. And the infections are still 15%, but it's not necessarily bacteremia, right? This could be meningitis, this could be abscesses, it could be other causes, right? We don't know, they don't tease that out. So if you combine those two together, bacteremia seems pretty low, infection isn't as common to kill our patients, and maybe we can start thinking about, do we have to admit all of our adult patients with sickle cell when we don't know the source of their fever? So we got to look to some guidelines again, right? So the National Heart, Lung, and Blood Association in 2014 released their guidelines on the management of sickle cell, all aspects, and this was a very tiny section on fever. They make the comment that there's no good data, so it's all going to be expertise, opinion, and once again, they're not very good. They give us some fever cutoffs. 101.3, arbitrary number, but if your patient has a temperature of 101.3, you should get labs. That's their first recommendation. If you're a child with that temperature, you should get a dose of IV antibiotics, and if you look good, you can maybe go home. So that's kind of important. If you have a high temperature greater than 103, you should be admitted irrespective, and then they just say, check for acute chest, check for osteo if you're suspicious, which we already know about, right? So what do we got on this? We got some arbitrary fever cutoffs, which there's really no clear indication why we picked that, but we have them. What's important is this idea that we could send at least pediatric patients home from the ED without knowing what's going on if they look good, right? So this is an algorithm that I think a lot of us are very familiar with. If you've worked in peds, right? We do this all the time if you have patients like this, and I've used this algorithm many times with our Penn faculty. This is the Children's Hospital of Philadelphia algorithm, CHOP. They've got wonderful algorithms for pediatric conditions in the ED. So you guys should really look up their website and read all their algorithms. They're really, really wonderful, really good stuff. And you don't have to read all this and know exactly what's going on. But the idea is that children aged 1 to 16 years who don't have any signs of bad infection, and their labs are okay within the parameters that they've created, their vital signs are okay, they have good follow-up, they don't look toxic, you can send them home. You can send them home for outpatient follow-up, and you can have them come back if you want to do a recheck. But the idea is that probably they can go home, they don't have serious signs of infection, we don't know what the fever is, but it's probably not that bad, and you can send them home and treat them in the outpatient setting. Now what's interesting is, so for years, I always look all into the other side here on the right side. 17 years and older, give levofloxacin and discharge, right? So this would imply our adult patients. I have no idea where they got this recommendation. I've looked I can't tell you how many articles I tried to read to find it, couldn't find it. I've emailed them, they haven't emailed me back still. Because they have a thing, if you have any questions about our algorithm, email you. So I thought this is gonna be great, and they haven't gotten back to me, basically. So I don't know where they came up with that. But that got me thinking, sometime like last year or 2 years ago, why can't we create an algorithm where 17 years and older we can do something in discharge, right? I know we don't have a lot of adult data, it's all pediatric data, and maybe people don't want to try to extrapolate it, but knowing that bacteremia is really low, we can diagnose the other serious causes of fever in the ED fairly easily. Maybe we can do the similar thing, create an algorithm, and we can treat our patients in the outpatient setting, basically. So I'm not the only one who thought about this. I was looking around different hospital systems in the country. In North Carolina, the state of North Carolina has this policy loaded on their website online. And this is their algorithm for adult sickle cell with fever, and it's an algorithm to potentially send them home. And what they've done, you can clearly see they copied a lot of the parameters in the CHOP algorithm from the pediatric data and the temperature cutoffs from the clinical guidelines. And if you make it all the way down to the bottom, if you look well, if your labs are okay, you get 1 dose of IV antibiotics, and in North Carolina at least, you get oral antibiotics and outpatient follow-up. Okay, so I tried emailing them. Is this really working? I didn't get any response from North Carolina. Okay, so I don't know how well it's working, but they're using it, right? They're doing it, so that's something important to consider. So can we just pick this up, paste it in our protocols, and start doing it here? Maybe not, right? And always the big caveat is, right, our outpatient follow-up system sucks, right? It's terrible. Our patients have a hard time navigating it. They might not follow it. So what do we do from here, right? Let's look at this a different way, right? If we admit these patients, and you admit them to me on the floor, what am I doing for this patient, right? What's a typical day on the floors at Kings County Hospital, right? So day 0, you guys already gave them antibiotics, you drew the cultures, and you drew the labs for me. I just have to go down, touch the patient, write my note, and that's it for the day, right? That's basically it. Everything's done. Patient boards in the ED for at least 6 hours, I put that conservatively at Kings County at least. Taking up space, they're getting coughed on by all of the sick patients, and it's not a good thing, right? It disrupts flow. So day one, I come in the next day, what do? I get labs one time in the morning, I give 1 dose of IV antibiotics, and sometime during the day, I look in the computer and see if the cultures grew anything that you guys drew for me. And after that, done for the day, right? I can go back to talking with social work for 18 hours, figure out whatever else I need to do, right? But that's it. As long as they're still looking good, I don't need to do anything. Rinse and repeat day 2, day 3 until my attending finally agrees that we can send the patient home, right? If nothing comes up. So if this is all we're really doing for patients that look good with a fever, we're just admitting them because we're concerned about the fever, can't we do this kind of in the ED? Right? Can't we just give everything on day 0, send them home, say, come back tomorrow. I'll draw labs tomorrow, I'll give you 1 dose of IV antibiotics, and I'll check your blood cultures in the ED. We could do the same thing, it's really no difference. Now, yes, if they need IV antibiotics, IV analgesia and things like that, you might want to admit them. But it's feasible. It's, in fact, it's very easy for us to do this. And it'll decrease the amount of boarding in the ED, save beds in the hospital, and it's probably pretty safe because we're not doing anything different than what I would do in the inpatient setting. Now, I already identified a problem potentially, right? How many days do I have to bring this patient back, right? Am I going to bring him back 5 days until cultures are finalized? That's going to clog up the ED if I keep bringing back all these patients. At that point, it would be easier just admit him to the hospital for 4 or 5 days, let them take care of it, send them home when the patient's ready to go, right? So here's a study done where, say in pediatric, I know we don't have adult data, but pediatric sickle cell patients with fever who had positive blood cultures, they looked retrospectively and said, how fast did these blood cultures return positive? When did we know? And basically, 17 hours was the average time, and by 24 hours, like over 90% had grown something, if they were going to grow anything. This means that 24 hours later, we check a blood culture, and we combine this with the idea that the pretest probability now for series bacteremia in sickle cell patients is very low. The chance of having significant bacteremia after 24 hours with a negative blood culture is very, very low. So we could probably have the patients come back, give them another dose, check their labs, they're looking good, labs are okay, and if their blood culture's no growth to date after 24 hours, the chance of them having significant bacteremia is very, very low. So, I think our fear of fever and sickle cell is very, very well validated, right? That a lot of bad things can happen, we have to be very, very careful. But this doesn't mean that we should just assume that if we don't know what it is, we have to put them in the hospital, right? Because penicillin vaccines have reduced the risk of serious bacteremia significantly. We're using PEDS algorithms that show we can safely treat them on an outpatient basis, and we do this every day, and there are 2 EDs. We don't have data on adults, but admitting them might be worse. For all we know, sending them home could be better. We don't know. So I think if we think about it, I think we can maybe somehow create some type of an outpatient model to safely treat our patients. So what's the overall picture of these 2 talks? We've come a long way in medicine. When you really look at where we've come from point A to point B, it has to make sense to you, right? You have to understand how we got here. You have to question, do I think this is how we should be practicing it? Or are we just practicing because we don't know? And if we don't know and you're not comfortable with it, start to think of new ways that we could start doing things differently, right? That's the only way we can advance ourselves, to start having ideas and moving forward. So that's it. I know I went over a little bit. Thanks to everyone here for helping out my lecture. And I know we're a little over, but I'd love to hear if anyone has any comments. I know like this is kind of like new stuff I'm talking about. I'd love to hear what you guys think about it. If it's feasible, not feasible, and what's our concerns.
First of all, great talk. I'm going to just ask a question about the sickle cell.
Sure.
I think it's totally reasonable. I've done it before. I guess the one thing, just since you've read all the data, has there been any comment or do you have any opinion on the difference between a pediatric patient who's on penicillin prophylaxis versus our adult patients?
Very good, right?
That's a big difference between the two.
Yeah, so, and I looked this up too, because if it was so good in the pediatric population, why aren't we just giving penicillin for life, right? And so there are a bunch of studies I didn't bring up here that they looked at after age 5, if you continue to get penicillin prophylaxis, the benefit decreased dramatically, and there wasn't much benefit. So the recommendation isn't necessarily to only give it between ages 2 and 5, but at age 5, you can make a decision as your oncologist, hematologist, whether or not you want to continue it. And the one recommendation is that if you ever did have a serious encapsulated infection, that you do get lifelong prophylaxis. But I thought the same exact thing, because I thought that was going to be one of my big points, was let's just give penicillin to everybody. But they looked at it, and for some reason after age 5 it decreases. Part of it might be that you can start to get penicillin-resistant strep pneumo, and also the rate of gram-negative infections might increase, so the penicillin doesn't help as much. But it's a great question, and that it is a big difference, but it doesn't seem to be a big difference in terms of giving it to them now instead of just up to age 5.
James, question about your syncope portion.
Mhm.
Do you remember there was like an article in Journal Club, in the Medicine Journal Club, this year is an Italian study where they screened asymptomatic patients with symptomatic but were otherwise asymptomatic for PE,
Mhm.
and they identified something like 1 in 6 patients admitted for syncope with no chest symptoms whatsoever ended up having a PE.
Correct. And I think that was the study, though, that we don't know what type of PE it really was, right?
About half of them were more than 25% of the pulmonary lumen.
Fine. But what's the mechanism of PE in syncope? Right, you got to think about it. That's why I bring this up. Why do we worry about PE and syncope, right? We're saying that the blood from the heart is not leaving the right side to get up to our brains, right? So really, the only PEs in my mind that kind of will cause that is if it's causing significant outflow obstruction, right? So even if you have a 25% PE in these patients, right, is that really the cause of their syncope? I don't know, right? The pathophysiology doesn't make sense to me. So that was always my concern with that study is we're saying they have PEs, and maybe even PEs we want to treat, but is that really the cause for those patients? And that's the only study I've ever read that had that. So I don't know. But that's always been my critique of that is really it's saddle emboli that we're really worried about causing massive syncope, right? These other PEs, even if they're not subsegmental, are they really the cause? It's hard to say.
But then also, pausing them doesn't mean that we're going to pick up these PEs more.
Correct.
You're not looking for it, you're not looking for it. On the observation unit, if you're not doing more CTA, everyone's not getting a CTA to a lot of PE, so I'm not sure if putting in the option is helping with the diagnosis.
Right? Because like I said, I think OBS is really for when we're worried about, or admissions, really when we're worried about electrical stuff when we need telemetry, because that's what we can't figure out in the ED. If we didn't think about it in the ED, then that's our own fault. But if we thought about it, like arrhythmia, that's the only thing we don't know necessarily. That might be what brings us in.
That's what I was going to say, is I feel like even options in this patient, the yield from the really much when the drugs, like, anecdotally, is so low.
Very low.
Like I've often thought with one of these patients, people like, order as many echoes as you want, and the chance of you finding some sort of valve is not good. Obviously, it's like nothing, you know?
And it,
Carotid valve, like all this other like kind of BS stuff.
super low. And it makes sense because why are we getting carotid Dopplers? We're looking for carotid stenosis, right? Right? Critical stenosis, right? It's so critical that you would hear it. If you actually listen to the neck, you'd have to hear it, right? If you have aortic stenosis that's causing syncope, it has to be so severe that you could hear it if you actually listen, right?
You have to have
So
it on both sides.
you have to have it both sides with carotid stenosis, right? So, I mean, if your physical exam, if you look for these things and you don't hear it, then it's not going to be clinically significant enough to explain your syncope, even if they have some aspect of it. I didn't talk about diagnostics, right? But we know you don't need routine CT heads. There's no routine labs. Troponins are not routine for syncope. Only 1% of syncopes present for MI. And in all the cases in some studies, you diagnose the MI and EKG, and the troponin didn't even help you at all. So this idea that we have to admit for serial troponins, there's no data on it. No guideline ever recommends it. The only thing that's recommended is an EKG. Everyone needs an EKG. And the EKG findings are clearly what stratifies you into high risk. And those are why those criteria work so well.
You know how often like in CED patients where let's say it's also reduced systems positive chest pain kids and they have all these other comorbidities,
Mhm.
they get risk-stratified and put a cardiac cath.
Mm-hmm.
You know that's like how often that happens.
Talking about cath for syncope? I
It
mean,
becomes a risk stratification to know the
so right, if you're cathing for syncope, it's because you think that someone had an MI. So right, if you don't think someone had an MI when you're putting them in the hospital for their syncope, how do you go down that path?
Or their EF is like 0, and you find it on your echo that you should work anyway. And you know if they have it.
If there's a new ischemia causing
Then
cardiac.
that's
Right.
non-original.
So right, if you get right, that's why 30% of patients get weird findings on imaging studies because you get admitted to the hospital. What do? Right? We order dumb shit upstairs, right? Pardon my language, right? We don't do good medicine all the time. We just order shit, and then it doesn't show us anything. So
It's not the rule out MI, it's not necessarily they have an MI, but it goes down this kind of parallel pathway of the rule out ACS and the patient side happens to have a provocative test that's positive for completely separate reasons.
different story. I mean, if you're admitting a patient for real ACS, you're admitting a patient for real ACS, right? But when we're on rounds, right, we say admitted to telesyncope, right? Those are the patients I'm talking about, right? Someone said, I'm just worried about syncope. And so the question is, were there really high-risk factors to keep them in the hospital? But you always gotta use your clinical judgment, right? You can't just use these rules and say like, oh, they don't fit the rule, I send them home, right? If you're worried about it, basically keep them. But if you're not that worried, and there's nothing that really leads you to be worried, I'm proposing maybe these patients should actually just go home and forget OBS in the first place.
Yeah, I think the other thing is, which you touched upon, is you can probably find some of the other diagnoses that led to syncope, GI bleeding, occult sepsis, think about it, find them in the emergency department. Unless they have conduction abnormalities or changed ECG, I don't admit any of these patients.
Yeah.
Often a discharge. If they're like old patients and it's like 11 o'clock at night, and they look a little scared, I'm like, what do you prefer? Do you want us to stay overnight? And then I say, I manage your expectation, like, you'll probably be here in this emergency department for a bunch of hours, but if you are more comfortable staying overnight, then we'll give it up to you, or leave it up to them.
Can you just clarify, I don't know if I was reading this right, but on the CHOP algorithm, I thought one of the lines said that all low-risk people you're considering discharging got a hematology consult before going home.
That's
Is that
for the
inaccurate?
CHOP algorithm, absolutely, right? So I'm not saying that we can just, once again, we can't just copy paste stuff. We have to work with our sickle cell division on stuff like this. But do you ever do that all the time in peds here?
No, we don't, but I'm wondering in terms of their application of this algorithm, how much of an X factor is that? Like, we don't know the data on when that does or doesn't change a low-risk person.
That's why I emailed them. Hopefully we'll get back to me any day now. It's been a couple of weeks now. But I wanted to know this, right? Because we use this all the time, and they seem like really great algorithms. But I was wondering the same exact thing, because I want to start that process if we can do it, you know.
Hematology always recommended being a sickle cell pediatric patient.
Yeah, right.
No, that's
Is that
not-
open?
no,
No,
that's
not always.